Okay, welcome everyone. Good afternoon. My name is Jen Hartman. I'm the manager of ambulatory pharmacy services at Freighter in Milwaukee. Thank you for joining us. This session is designed for pharmacy students, pharmacy technicians, and pharmacists. In this session, we'll explore the impact of hypertension in the U.S., focusing on its prevalence and serious health risks when uncontrolled. You'll learn about a pharmacist-led remote patient monitoring protocol using self-measured blood pressure and how this approach improves patient outcomes. This is a great opportunity to see how pharmacy professionals can lead in managing hypertension through innovative patient-centered care. Please join me in welcoming Dr. Zach M. Hovis, Assistant Professor at the Medical College of Wisconsin School of Pharmacy since 2021. Dr. Hovis earned his PharmD from the University of Connecticut and completed a PGY1 community pharmacy residency at the University of Wisconsin. With over 7 years of ambulatory care experience, including roles at UPMC and SS17 medical care, his interests focus on value-based care, pharmacy practice expansion, and population health management. Dr. Hovis is passionate about engaging pharmacy learners in innovative ways to apply their skills in today's evolving healthcare environment. Full speaker bios can be found in the conference app. Please join me in welcoming Zach.
Hello everybody, and hello to my fan club here in the front here. Enough once you have you. All right. Let's see. Probably gonna do this so slides. Yes, sweet. Okay. Hello everybody. Thank you for coming to my session. It's Friday for me. It's 4:30. But try to make this interesting and engaging because I know there's probably a lot of other places you'd rather be. It's beautiful outside, and there's a party tonight, so. Not that this is going to compare to how much fun you're going to have tonight, but well, yeah, I'll do what I can. So, no relevant financial relationships to disclose for you, and the learning objectives are listed here. I'm not going to do it for you. They are in your slide deck. So today I'm going to talk about the model of care that we use at Freighter for remote patient monitoring for hypertension. But before I dive into the model, we'll just kind of set the stage a little bit and talk about the problem of hypertension. This is not new statistics. My guess is everybody in this room is familiar with some of these data points, but just to level set and present the opportunity to you. We know that hypertension is the most common primary diagnosis in the US. About half of the adult population in the US either has formally been diagnosed with hypertension or would meet the diagnostic criteria for hypertension, which is defined as blood pressure greater than 80. And about 1 in 4 adults with high blood pressure have their blood pressure under control, right? So we have a primary disease where half the population has the disease. Only 25% are under control. So this leaves 75% and 50% that is uncontrolled, which is a massive opportunity given that we are well positioned as pharmacists to help improve upon usual care systems. So again, I'm going to be presenting on one model that we're doing to disrupt our usual care system to try to improve hypertension management. There's some interesting demographic factors to present to in hypertension. Higher percentage of men have hypertension, unsurprising at this point, but non-Hispanic Black adults have the highest prevalence rate of hypertension at 56%, with non-Hispanic white adults after that, and then non-Hispanic Asian adults and Hispanic adults, lowest at 30%. So again, a significant portion of the population has hypertension. And then in terms of age, we know that as we age, hypertension incidence increases. So our lifetime risk of developing hypertension amongst normotensive individuals, age 55 or greater, is 90%. That means most of us in this room at some point in our lives will be diagnosed with hypertension. So this is a problem that will probably impact all of us either directly or indirectly at some point in our lives. This is a national map of hypertension prevalence. We can see, if you take a look at the map, It's concentrated really in the south is where we see the darkest red, the highest prevalence rate. Not surprising if you were to overlay ASCVD on here, you'd see a very similar map. But if you look at Wisconsin, we're doing pretty well to the national trends here. Zeroing in on Wisconsin, you can see a breakdown of where we see concentration of prevalence of hypertension. And Milwaukee County, surprisingly, is one of the highest counties in the state that has high prevalence rate of hypertension. And then we have a smattering in the center of the state and the northwest part of the state. I'm drawing your attention to Milwaukee County, that's where we are right now, and happens to have one of the highest prevalence rates of hypertension in the state. Okay, so SNBP. It's come to my attention that new hypertension guidelines were released yesterday, which of course, the day before I'm giving my presentation, they released new hypertension guidelines. So my sincere apologies. I have not had a chance to look at them yet. My daughter, my wife, actually both of my daughters and my wife have strep throats. I'm like trying to manage that, teaching. I had a clinic day yesterday, so I haven't read them yet. So if you've read them and this is out of date, I sincerely apologize, but I'm going to read you what's in 2017, then we can kind of compare maybe together in, at least for these days, we can compare these together maybe next week. But 2017 ACC/AHA guidelines say that out-of-office blood pressure measurements are recommended to confirm the diagnosis of hypertension and for titration of blood pressure lowering medication in conjunction with telehealth counseling or clinical interventions. So that part is key, because we know that if somebody engages in self-measuring of their blood pressure without any sort of telehealth follow-up, there's no statistically significant reduction in their blood pressure. So there has to be this feedback loop of we do something with the data that's collected by individuals who measure their blood pressure at home. So this is what we're going to talk about. So what I want to do now is engage you in a slide question. And I want to ask you, as far as you're aware, do the patients that you serve have access to self-monitored blood pressure paired with telehealth counseling and or medication titration from a non-physician clinician? I'm just curious to see it. I know we've got community pharmacists, we have pharmacy technicians, we have a fair number of pharmacy students, other pharmacists from different health systems. So I'd love to. Takes a little bit. But we have most people saying yes, a fair number of people saying limited or no resources for SNBP. SNBP only maybe is like you can, maybe if you work in a community pharmacy and you sell a in your pharmacy. SNBP plus physician follow-up, maybe primary care doc in your area has told you about this or patients told you about it. Okay, so most of us haven't. A fair number of us have limited or no resources for SNBP. The rest of the presentation, I think, is probably geared towards those individuals who aren't aware of available resources, and maybe to think about how can you try to work with health systems in your area, or if you work for the health system in your area, how can you work with your administrators, upper management, for trying to involve pharmacists in this work, right? Because we know hypertension is an issue. A lot of people have uncontrolled hypertension. Usual care is not working. Pharmacists are great disruptors of trying to change practice models to improve chronic disease management, specifically in hypertension. So I want to introduce you to digital care monitoring. So this is our solution for you that we launched in fall of 2020, where this is our remote patient learning program for patients to measure their blood pressure at home and engage with our team to try to improve their blood pressure management. So prior to launching, we identified a vendor that we work with. I have no skin in the game here, nothing to disclose with respect to his relationship with this company, CareSignal, but that's the vendor we landed on. So CareSignal, we like that because they allowed us to interact with patients via text message and IVR, which for us is a low-tech solution. It's about like Epic has MyChart. MyChart is one area you could choose to use this or collect information from patients. But a lot of our patients with uncontrolled hypertension choose not to engage with MyChart. Most everybody we use in text messaging. So it's an easy, familiar context to send clinical information. So we utilize text messaging patients twice a week reminders to send us blood pressure readings as it comes to our team, and then we can make treatment decisions based on that. And this is layered on top of primary care. This is not obviously meant to replace primary care. This is meant to fill in the gaps between some of the follow-up plans that are in place for patients. So if a PCP makes an adjustment to an antihypertensive and says, follow up with me in 3 to 6 months or something, and the patient doesn't schedule an appointment until 9 months, and they go that whole time with uncontrolled blood pressure, this program is meant to try to get the patient under control faster and overcome that clinical inertia. This is our 2,000-foot view of the program, and then I'll talk about the components in future slides in a little bit more detail. But in general, what we do is identify patients that are good fits for this program. We do a mixture of automated enrollment. So we identify a list of patients twice a month based on our inclusion and exclusion criteria. Or we can have providers that send direct referrals if they think they have a patient who would benefit from this program. It's a combination of all those things. That list gets sent to our vendor, a team of specialists. They call the patient and they offer this program to the patient. It's completely voluntary. They'll offer it with scripting that we've approved. So this is what we should say, and this is how we want you to represent us. And the patient can choose to accept or decline. Of patients that we identified for enrollment, we have about a 25% enrollment. So 1 in 4 patients is saying, yes, this sounds great. I will join this program. I will send you my blood pressure and potentially engage in that titration or vice versa. Patients then send us data. We send a reminder twice a week to send us blood pressure readings. I was just at the billing sessions before this. As they pointed out, speakers pointed out in that session, I think the Medicaid billing requirements. We need patients to send 2 blood pressure readings 1 minute apart twice a day for 30 days with a minimum of 12 readings in a 30-day period in order to be eligible for billing. We do not bill for remote patient monitoring codes through SNPP. We don't have the frequency to justify that billing right now, but it's something that we will look into. But at this point, but that's probably a question that get haven't justification if we have time to do it, but then we get data into 3 low risk groups, and then based on the risk group, we have different interventions that our clinicians undergo escalated to different decisions. So that's sort of the general flow of this, but let's break this down further. For our enrollment, I mentioned we have this batched enrollment. So it's automated based on our inclusion and exclusion criteria. Inclusion criteria is listed here. I think the one that usual scratching is they have to get this one. That's for us to make sure that they're willing to and able to take an antihypertensive medication, and also to ensure to use that as a surrogate marker for a hypertension diagnosis. We have a hypertension registry that is an EPIC, but it's imperfect. Lots of patients have not hypertension and hypertension registry list. So it's our way of protecting against patients who don't have hypertension. And then we have the average of the last 50. We can find it's pretty important. Maybe last one is uncontrolled. Now, students are probably sick of me talking about this, but you notice that blood pressure reading is 140/90 as opposed to 130/80, which is what the guidelines, to my knowledge, said that did. I think the new guidelines are still 80s. As a quality measure, so he is ready to start. Threshold that they have for controlling their blood pressure is greater than 140. So that's a threshold. And then we exclude patients that are not rated to be pregnant, stage 4 or 5. It's hard to. And then they follow last year, we exclude. And the reason for that is we don't want too many cooks in the kitchen. We expect expansion. We don't want to be dosing antihypertensive, so the cardiologist is saying they do a different thing. The patient's not sure who to go to for the intensive care. We want them to go to specialists. That's who's managing. I mentioned our role already, that is that phone call, and we're using this guys. Talk about this program. We're in the age of like generative AI scandals, so I can tell you, you're getting it on if I don't know what the number is from. Our patients are no different, so we try to make them aware of the fact this. And then once the patient has chosen to enroll, then aided by our system helps set the patient up essentially to add medicine care and send this over to the provider, they should have medication. These are risk categories. I will state that these risk categories were selected by our team because of the staffing model that we had. So we were pretty slim staffing. The risk is 160 over 100. Somebody who's got one like 155 over like 95. Think they needed escalation or the most intensive intervention. And I don't disagree with you. You had better or more clinical pharmacy resources. I think we would probably tweak that threshold. If you're looking at this and thinking that I get a similar practice, you could choose a different threshold. But this is what we started with for patient volume. To this patient volume. So red risk is 160 bigger than 160 over 100. Yellow is 146. And then here's our period intervention. So red risk is going to get pharmacist intervention if they're appropriate patient. Yellow risk are going to be early interactive white messages with lifestyle interventions. So we have 5 different lifestyle interventions. The dash diet and 150 minutes of moderate intensity aerobic exercise and increasing dietary potassium, decreasing alcohol intake, and then so those are the 5 factors that will send a message, and then we try to engage the patient as to any one of these 5 that you would be willing to work on and you think you could improve your life, and try to do a little bit of motivation. And the green misery gets added back once a quarter, great job, people. We do have an alert pathway, so if somebody sends us 100, that comes to our MA as a high-focus message. Our medical assistant will then outreach to the patient, get a little more information. Did they take their medications? Can they take their blood pressure again? Do they have any symptoms of emergency? The answer is yes. The medical assistant, so we're not telling the patient to go. They're escalating this to triage persons because I am not in the clinic every single day. I'm in the clinic twice a week, so I'm not the best person equipped to handle these urgent messages. Triage nurse team. That's what they said to triage. All the patient determine if it's urgency or. So our interprofessional care team is comprised of this medical assistant, who for our team is 0.5 minutes. The medical assistant does a ton. She's sort of the front line. She's gets my name. She does a really good job. And she takes on a lot of roles and responsibilities as like the frontline person. She's the one who's answering the phone. She sends referrals for hypertension management, which in our system is our CPA. So she'll send the physicians, the science needs to make those adjustments. She'll help schedule appointments for patients. She'll engage. She helps set up those quarterly HR messages, etc. She does a ton. Very high skilled position. I think this position could also be good for a pharmacy technician if you're thinking about how you have some type of support staff. I think there's nothing specific. There are some just about our type, namely that really goes it's now like scheduling system. But if you've got a small practice, FQHC, community pharmacy, I do think a pharmacy technician could certainly possess the skill sets to be able to be a really good frontline staff. And then we have the pharmacist in our hub. It's 44 twice a week. Initiative. So this is probably the most things about this model is how slim our staffing is. A lot of, I think, the barriers to having a pharmacist involved in this type of remote patient monitoring is just cost, right? Pharmacist FTE. Ideally, you have like 2 pharmacists doing this full time, but it's hard to financially justify that. And certainly for big population health initiatives like this, it's great to be able to take care of a lot of different patients, risk stratify, have pharmacists focus the red risk patients. And we support the figure here. So we've got big size statistics. Jordan's that there's like 1 million visits that happen. So we have a lot of patients that are seen here. So we support all care, deal with slim staff. Okay, so then what presents is here. A journal published in Journal Pharmacy back in December. So if you're interested in reading the full article, I very much encourage you to send me the end of it. Maybe thank you slide, question slide, or you can just get it in program brochure, but send me an email and I'll send you this to the student. But these are results from data that we collected from October to July 2023. We had 653 patients that we included in a data analysis. So those are patients who enrolled for 12 months. You can see now we have a breakdown here. What's our government students? About 3/4 less than 64 years old, and 1/4 elderly, 50 male, female. Majority of my patients, with 36% of patients being a category in primary and secondary outcomes. Primary outcome was achievement of blood pressure control, which we defined as less than 140 or less than 80. After being enrolled in the program for 12 months, using clinic measured blood pressure reading. So not using a home readings, this is blood pressure readings in the clinic. After they've been enrolled in the program for 12 months, the blood pressure reading is most recent, but now 12 months. And what we see is 80% to 72% of patients who were uncontrolled when they were enrolled in the program by definition. After being in this program for 12 months, 80% of them, but 80% of them achieved control, according to the following. And then we look at the systolic diastolic to about 20 over 14 millimeter blood pressure reduction for being a part of this program. So very favorable. Very pleased. And when we looked at variables, we saw that benefit was seen regardless of age, the race, ethnicity, sex, demographic. Any statistically significant difference in the change with age, and we saw that older patients had more benefit than younger patients, but both groups had statistically significant pressure reductions. So benefit was still there, it was just more pronounced. Benefits. Basically, sex, age. I do want to temper the enthusiasm and excitement because there's definitely some limitations that I'll make sure you're aware of. First being, it's a single center rigorous following treatment initiative. We have no control group that we're comparing to, right? So patients are essentially serving. There was no end region. It's voluntary enrollment. So if you think about this, I said 25% of patients who are offered this program chose to enroll. So who's choosing to enroll in a program like this? It's probably going to be you're highly motivated, somebody worried about the fact that hypertension, maybe they have a family member who had a stroke, but they don't want to have to that, right? So there is this idea of self-selection. It's maybe the other 75% may have the same. Actually, we have no control group, and they're working on it's going on their fingertips related to hypertension. One specifically that I remember is this is when we rolled out HR blood pressure. Basically, looks at patients can send us blood pressure readings via my chart. So that was going on. it's in theory, it's possible a patient who did both that and this program. So they sent an itinerary readings to their provider and did this. There were various issues going on. And at the time, basically, 75 excluded all patients. We have since secured funding, so now we actually do offer that to our patients as a part of Baird. Okay, so that's the program in a nutshell. Why should you care about this? Well, hopefully you're thinking about this in terms of how this impacts your own patients and how you might be able to set up some type of where your patients could engage in some type of SNBP with a non-physician clinician following up a pharmacist. Hopefully you're thinking about that. You can use this as a conversation point, maybe it helps stimulate some thought to be involved in this work. And I also want to make everybody in this group aware of the AHW, so Advancing Health Wisconsin, for control education. AHW is a nonprofit, Wisconsin, aimed at Wisconsin. They have announced that they want to dedicate a serious bit of money to help them solve this issue. At this point, what they've done is they've identified this practice as the backbone, what they want to use for changing hypertension management in the state. And they're going to start in our region in southeastern Wisconsin. So I'm working very closely with AHW, with Freighter, with 16th Street, with a lot of the community organizations. We get started to help flesh out this practice. How do we want to offer this for all patients living in southeastern Wisconsin, and eventually for all patients in Wisconsin? So I think the vision is anybody who lives in Wisconsin should have access to some type of program where they can measure their blood pressure, send it a team of clinicians, and then adjust antihypertensives. So we're trying to figure out the best way to do that using this for integrated delivery clinics that have access to a pharmacist, but I think there is some desire to do this for even rural areas that aren't part of, don't have integrated delivery networks that are close by. So hopefully that's a good thing. Wow, amazing, 2 minutes left. There are minutes. I should know but Merlin, also like to notes. It's a deal. It's funny. And then any questions? I hear the messages down there. Okay. Which of the following reasons or innovation is indicated for hypertension states? I'm going to slide. What do you think? Students want a shot at the answer? Who's feeling confident? See, I can do this. Left out. We like it. I don't like B. B should be one. True or false? It's not 20. It's false, yes. Which of the following is a key function of the medical system that digital care monitoring? I heard an A. It's very good. It's not only not adjusting for therapy. True or false? The technology discussed in the presentation lets a patient collected treatment be read. Christina's giving me a T for true. We're happy. Yeah, it's true. And then what was the primary impact of the digital care monitoring program? The increased medication adherence, significant reduction in SVP and diastolic blood pressure. That's good. Cool. And then this is the last one. Which of the following best describes a key component of the tiered pharmacist-driven patient monitoring protocol discuss today. Did we talk about AI? Not yet. That comes next year. Okay. Standardized patient outreach delivered by either a medical assistant or pharmacist. That sounds pretty good. Mandatory daily in-person clinic visits for all participants. Exclusive alliances. Really. Thank you very much. What's any other questions? Anything?
Okay, I'm ready to go out. Can you hear me? Okay, good. So in a lot of primary care clinics, nurses are heavily involved in this sort of work, the assessment, the management of the job they find in patient. Just wondering if that model existed at Frankfurt, and if this model replace that, if it did, what the nursing staff was, because I'm assuming this is like something that nursing really enjoys doing, top of their practice, that's a good thing, and they're really like part of the answer.
Yeah, that's a very good question. So my knowledge, there was some sort of like scope creating conflict with nursing. A patient could still send in their home blood pressure readings via pie chart to a care team and engage with nursing and the primary care provider in that way if they chose to. So this is more of like a proactive approach where patients are sending those readings via text message to us as opposed to maybe coming in the clinic for like a nurse-directed blood pressure visit or a program where nurses are leading this. But to my knowledge, there was no system-wide home blood pressure initiative that was run by nursing. Every single clinic, the culture is a little bit different. So I can envision if you have a clinic where this is nurse-driven, and then you try to pitch this idea that like, hey, the pharmacist is actually going to take this over, that probably would have some. I can envision there would be a little bit of conflict there, but the amount of evidence that's mounting for pharmacists to be involved in this work would be a compelling argument to have the pharmacist be the individual who's adjusting pharmacotherapy. Maybe there's still a place for nursing to be involved. Blood pressure, cuff validation, lifestyle interventions, motivational interviewing, but I could make a strong argument that the medication expert should be the one who's titrating medications and selecting what's the next appropriate step in therapy, and what lab monitoring should we be doing. So from that standpoint, I haven't had any pushback from nursing at all, but every organization's different, tread lightly, and it's hard to please everybody, but we have to try. Good question. See, no other questions, but thank y'all so much for your attention. What do we, oh yeah, you need to see, thank you. So everybody actually came. It was good.